Thanks for joining. My name is Joe Diamond. I'm a physical therapist at React Physical Therapy up in our Deerfield location. So like I mentioned a minute ago here, I also have Scott Robin, who's another physical therapist at our Lincoln Park location. He's joined us as a panelist. So he is here kind of monitoring the chat function. So if you want to send a chat either to everybody or just to the panelists, which is me and Scott, then that's one way you can have some answers or some questions answered. I'll check it periodically as well, but Scott will be on there kind of monitoring that the whole time. So thank you, Scott. And thank you guys all for joining. So I can't hear or see anybody, so that's the only way you can kind of tell me your questions, but I appreciate you all being here. So today we're about to talk about the knee. The knee is, a really common place to have aches and pains, and it's also kind of a common place to have more serious injuries. And I feel like it's important to know what's actually going on there. So this is not geared towards a specific type of injury, like rehabbing from a specific tear or injury. It's kind of looking at the knee as a whole. And I kind of want to help you have ways to either help minor aches and pains, prevent bad knee injuries, or kind of just know more what's going on if you do have some kind of knee injury or history of knee injuries. Okay. So I'm going to pull up my slides here. Just a moment. Okay. Hopefully you guys can see this. If you can't, somebody say something in the chat. But like I said, we're talking about how to keep your knees healthy and pain-free. So we're going to talk a little bit. First part, we're just going to understand the knee. I'm going to go through anatomy, biomechanics, how the knee moves, sources of knee pain. We're going to talk about the lower extremity kinetic chain. So a little bit outside of just the knee, but the surrounding areas as well. And then we'll get into prevention or treatment of knee pain. And then at the end, I'm going to demonstrate a couple exercises over here in the clinic that you can try to either prevent or kind of alleviate some knee pain. So we'll start with anatomy. Most simply here, I've labeled the bones, right? These are the bones that are involved in the knee joint. And then joints are very literally named by basically the two bones that they include here. So the biggest part of the knee is the Tibiofemoral Joint, which includes the tibia, shin bone here, and the femur here. So it's this whole big surface in the center. That's the big mover of the knee joint. It's a synovial joint and so basically that means that it has a joint capsule around it. Here in the corner, you can kind of see a little hologram of a joint capsule. So that kind of stabilizes the joint. And it also means that there's synovial fluid inside, which kind of like nourishes the joint and helps it move better, glide better. The surfaces of all these joints are covered with cartilage. So that's what else is in between the joint there. The other joints that are at the knee, the Patella Femoral, again, it's just named after the patella, which we know as the kneecap. And the femur. So the patella kind of sits in between these two ridges on the femur, and then the patella actually will glide up and down as the knee moves, and we'll kind of get into what makes that happen later. The last little part here that's by the knee is tibiofibular joint, the proximal part of the tibiofibular joint. And this joint does not have a lot of movement, like really minor gliding at that joint, but it's also at the knee here. So next in the knee, we have a very stable joint. Ideally, we have a lot of ligaments and tendons and things like that that add to the stability. So you've probably heard the acronyms. So we have ACL, PCL, LCL, and MCL. So the ligaments in the middle here, deep inside, so it's in that joint capsule, in between those ridges of bone, are the ACL and the PCL. So the anterior cruciate ligament is in the front, and it crosses this direction from outside to inside. That one prevents the lower part, the tibia, from going too far forwards, on the upper part. It also prevents a little bit of inward bending here. The other one behind it you can't see very well is the posterior cruciate ligament. So it's just the one behind that one, and it kind of goes in an opposite angle, so they make a cross. That one prevents the tibia from coming too far back on the femur. So it's talking about this bone relative to the bone above here. So obviously you hear about those in sport a lot, and we'll get into that later, but the other two ligaments, MCL is the medial one, so the inner side. Medial always refers to towards the midline, the inside, so that's over here, and then lateral over here. So those are very thick, strong ligaments, but again, with big injuries, they can get injured. We'll go to the next slide here. Oh, I guess I didn't cover one ligament here yet. So the patellar ligament goes from the kneecap down to this ridge on the tibia bone, but I'll get more into that in a minute. So a very special thing that we have in the knee is the meniscus. So that's a connective tissue that helps with a couple different purposes. So the meniscus is kind of this like figure eight. It's two kind of horseshoe shaped things here, and they have a couple of purposes. So one, I mentioned the articular cartilage. I guess I'll talk about that first. The articular cartilage is this smooth, shiny stuff along the surfaces of the bones where they connect. So everywhere that the bones are gliding on each other, it's very important to kind of keep it smooth, help it glide and protect the bone that's underneath there, because otherwise it would just be, bones and it wouldn't be very smooth. So the meniscus is on top of the articular cartilage there. And what it does is, for one, it distributes the forces. So instead of, this bone smashing on this part of the cartilage all the time, it kind of distributes the load of your whole body weight while it's coming through this knee joint so that it's more evenly distributed. And then second, it also helps with stability, because you can see it's kind of like a cup shape. So it kind of helps those ridges stay within each other and not move side to side too much. In terms of neurovascular supply at the knee, in the back here, you can see the arteries and veins. The popliteal artery and the branches of it supply the knee, and then further down the leg as well. And then for nerves in the back of the leg as well, this is looking at the knee from the back in between the hamstrings here. You have coming down, it would be the sciatic nerve. And then down at the knee, it will branch into tibial and common peroneal nerves. So that is right behind the knee here. The only thing that is separate from that is that the quadriceps muscles in the front of the knee are innervated by a different nerve, which is the femoral nerve. So this part is interesting. I feel like this is something that people don't know we have in the knee. Like, everybody may have heard of some of the things we've talked about so far to some degree, but most people don't know what a plica is, for example. And sometimes, knee pain isn't very straightforward, but sometimes you can have pain from an inflammation of something like a plica. So I wanted to put it in here. So plica are basically like folds in the joint capsule lining materials. So the most common one that bothers people is this medial one. So it's kind of just like a fold of tissue in there. And sometimes you can feel it. It's like a ridge or something. Usually they don't really cause problems, but sometimes that can get inflamed. And then a bursa is similarly, do I have it on? So it's kind of like a padding in between these connective tissues, and it's another thing that can get inflamed sometimes and painful. So moving on from anatomy, did anybody have any specific questions of those? I can't see the chat right now. Okay, well, I will come back to your questions if you have them. But moving on a little bit here, we'll talk about knee biomechanics. So the knee has basically one main function, a main movement that you can see, and that is just bending back and forth, right? Flex is bending, extending is kind of straightening out all the way. So ideally you have full extension of 0 degrees, and it's also normal to have a couple degrees of hyperextension, so a little bit beyond that, like pushing the knee a little bit further down. And then for flexion, normal is about 130 degrees, but you can do most things functionally with a little bit less than that. There are some things noted on here, but so basically, if you're really, really limited, it would be hard to climb stairs. But 130 degrees is technically full range of motion there. Besides flexion and extension, there are kind of some accessory movements that happen at the knee, but it's not kind of like a big movement that you would see like this. And those are rotation of the tibia or the femur on each other. So that upper bone and that lower bone can kind of rotate just really slightly. And the second one is Varus and Valgus directions. So that is basically, if you looked at those two bones that we had in that picture, and then if you were kind of like tipping them and stretching those ligaments on each side, those are a Varus or Valgus force. So obviously it doesn't go really far unless, you know, that's how we test for those ligament issues. But typically that doesn't go very far, just an accessory motion. So where we see the rotation of these bones functionally is in something called the screw home mechanism. So every time that you bend, that you go from a fully locked extended position, like you're standing, and then you go to bend, like to go to sit down, for example, there's kind of a locking and unlocking that occurs between those two, the same two bones that we were talking about, the tibia and the femur. So basically those kind of notches on there, in order for it to efficiently lock and unlock, when you're getting into extension, the tibia will externally rotate in relation to the femur. And then that puts it kind of in a more stabilized position. And when you're coming out of that and unlocking, then the tibia actually internally rotates on the femur in order to unlock. And that is by the popliteus muscle in the back of the knee, which is a little muscle right kind of in the pit of your knee, if you will. So just as important, almost just as important to the knee function is the function of the joints above and below it. So we've been talking about the knee, and we've talked about like all the stability factors that there are there. And we've talked about the one movement basically that it does, flexing and extending. So luckily above and below the knee, we have a lot more movement, otherwise we'd be pretty stiff. So in the hip, it's a ball and socket joint. And look how much movement you get from your hip. So flexes a lot, extends, it goes out and in, abduction, adduction, and then it rotates externally and internally. So that's a lot of movements, and all of those are movements you can like see with your eye, kind of big ball and socket mobile joint there. And then below at the ankle, we have kind of a complex situation with a lot of different bones, which means a lot of different joints, and again, a lot of planes of movement. So the foot and ankle move in dorsiflexion, plantar flexion, eversion and inversion, and then as a whole is pronation, supination, and in and out rotation. So this will be important in a minute here when we start to kind of piece things together, but just note how much more mobility you have in those joints. So here we are, we're gonna talk about kind of like putting the body as a whole together. So we talk about this a lot here at React with our patients, and everything we do is, you know, when you have a knee injury, we don't just look right at the knee, because a lot of times there are things above and below that are leading to it. Just like when we look above and below, we can see, you know, where your imbalance is maybe coming from somewhere else. So this is kind of just a good graphic of, you know, if there's a change in like your pelvis positioning, or, you know, you have limitation in your spine range of motion or something like that, that it's going to affect like the position of your leg bone here, femur, which then affects the position of the lower leg bone. So because everything is interconnected at these different levels, these different joints, a force or a change or a limitation in one can end up, going up or down the kinetic chain, we call it. So one kind of knee specific thing that we really look at is here, the Q angle. So the Q angle is from this kind of landmark in the hip, the ASIS, to the middle of the patella or kneecap. And then from there to this another little landmark on the tibia bone. So if you can imagine a little line here and then a line all the way up here. This picture is depicting basically like a huge excessive Q angle, but typically in men, it's average about 13, like maybe 10 to 15 is normal. And in women, it's a few degrees more for the Q angle to be like 13 to 18, about 17 average for the Q angle. So if you have an excessive Q angle, like depicted in this, it affects this, whenever you use your quads, which is all the time during functional motions, it affects how the kneecap, the patella, is being strained, pulled, and it also affects all the muscles on the outside, the muscles on the inside, the muscles in the lower leg, and then you can see the knee joint here is in a little bit different position. So long story short, we have to look at the whole body as a whole here. Hold on, I see a chat here. Okay, so this is a good question. We have a question about knock knees. Knock knees is basically talking about genu valgus. So when we talked earlier about valgus or varus forces, so it's kind of like that tipping. So Q angle, it could often come with Q angle, and it's similar to this. It does look kind of like this, but sometimes that knock knees valgus force is less about rotation. So the Q angle is more about the rotation of the hip relative to the tibia. Sometimes they can come together, sometimes not, basically, is my answer. But either way, there are ways to prevent or like address this type of situation. All right, so finally we've gotten to the muscles here, which is very important. I feel like I didn't cover the patella so well earlier. So the patella is kind of a floating bone. It's that kneecap, and it is held between the quadriceps tendon. So the quadriceps are 4 muscles in the front of the thigh. They join to the tendon, encapsulate the patella here, and then that connects down with the patellar tendon to the front of the tibia. So it's kind of like a whole complex. So if you have, a problem down here at your patellar tendon, it would be, we are gonna look at the quads as well, and vice versa. Okay, but moving on in general, the muscles that are involved in knee health. One, most straightforwardly, is the muscles that cross the knee joint. So that's the quadriceps in the way that I just mentioned there. In the back, the hamstrings. So quadriceps are 4 different muscles. The hamstrings are 3 different muscles, 2 kind of on the inner edge and 1 on the outer edge. They kind of attach to the sides here. And then the last is the part of the calf muscles, the gastrocnemius. So that's a 2-headed muscle, and that attaches like just above the knee joint there. And then I don't think you can see any of these pictures, but right in here, kind of going side to side at an oblique angle, is the popliteus muscle that I mentioned for the unlocking of the knee. The other thing that does cross the knee joint is the IT band. And I feel like everybody knows the word IT band, but not everybody knows what it really is. So this stuff is muscle, that's quads, this is hamstrings. This white thing is the IT band. So it's actually a thick connective tissue, like band. So sometimes when you just roll on your IT band, you're just kind of like pushing on this really tough band of connective tissue. So a foam roller basically can't attack this tough band, but what feeds into this band is a couple of muscles, the TFL muscle right here, which is a hip flexor and rotator, and the glute max muscle back here. So those muscles feed into that tendon band. So sometimes you can kind of try to address if those are tight and that's contributing to your IT band tightness, because the IT band does come over to the outer side of the knee here. But outside of the muscles that just actually physically cross the knee joint and make the knee move, we have a lot of muscles that can affect the knee very importantly. So we have gluteus medius and maximus, especially the gluteus medius. We'll talk about a little more, but that is the one that kind of prevents the hip drop or the like knock knee situation that we saw in the other picture. So that is actually shown to be a really big factor in some of those, in some cases of knee pain. Hip flexors, abdominals, low back muscles, and then the lower in the leg, the little muscles that stabilize the ankle and the arch. And then honestly, sometimes even other muscles can have an effect and contribute to your knee pain. Check the chat here. Okay. Yeah, so I think we've got the question answered here. Okay, moving on. So what causes knee pain when you do end up having knee pain? So there are multiple things. One is biomechanical reasons. So if you kind of just look at everything we've talked about, both at the knee and surrounding it, I'm basically talking about either biological hereditary changes in your anatomy, because we're not all perfectly symmetrical and the same as everybody else, or so anatomical changes, or biomechanics, as in some things, some muscles are not working as efficiently as other muscles, or, you know, side to side we have some asymmetry or things like that, that end up putting extra strain on certain tissues that can become painful over time. And then we have inflammatory, so like arthritis, we'll get into that in just a moment. Structural injuries, so like something happens and a structure is injured in that way, like a tendon or ligament, a bone. We'll get into that again in a minute. There are rare causes of knee pain in the other category. So rarely it could be because of a malignancy or infection. Sometimes knee pain comes from the hip, like you have an injury in your hip and where you feel it is your knee. I've seen that a couple times with certain, especially in kids, there are a couple of conditions that actually do present like that. And then sometimes I've had a couple patients come in for treatment on their knee, and we found out that their knee pain was a back problem coming from a nerve in their back. So there's always other things to consider. The first ones I mentioned being rare. And then usually it's some combination. So maybe you have a partial injury, like a repetitive overuse type of injury in one of your structures, but maybe that's because your biomechanics have been kind of off for a long time and you've been doing some activity a lot in that way. And so it requires some changes. So going back to arthritis here, osteoarthritis is the main one that kind of most people are usually talking about. And that causes degeneration over time of the articular cartilage. So that lining that was in between all of these joints. So it breaks down that lining over time, causes pain, sometimes swelling and things like that, stiffness. And sometimes it affects the bone underneath, depending on how advanced that is. So this is affected by age. If you've had a prior trauma or injury in the knee, that can have an effect as well. But there are a lot of big myths about this. So one, over here on the side, you can see, I just kind of wanted to show what I mean in terms of arthritis, but we're not going to pay too much attention to that because like a person in this picture could have been, feeling great, going for hikes every day, doesn't really have major knee pain. Whereas somebody with a picture with like a couple spots of arthritis could be kind of debilitated and not be able to do their daily activities. So basically what I'm trying to say is that the images like this, x-rays, don't always correlate to the level of pain or disability that someone has. So, you know, don't get too freaked out if somebody tells you you have arthritis in your knee, but you're feeling good and taking care of yourself. Another big myth is that exercise is bad. So some people are like, you know, don't run so much, your knees will get arthritis or hurt. So on the contrary, there's been a lot of research about this, and a big systematic review showed that actually there were decreased cartilage defects and cartilage loss. I don't think it's specified, but with vigorous exercise in that study, it said. So over a long period, actually less cartilage loss. And they might have had some changes in the bones, but it didn't necessarily correlate with pain or with cartilage loss. So they're actually wondering if exercising intensely or a lot throughout your life actually helps joint health rather than, you know, beats them up or wears them down, which a lot of people have worried about. Another arthritis is, the second most common one is rheumatoid arthritis, which is kind of more systemic. It's an autoimmune disease that causes inflammation in the joints. And this one typically will be both knees and some other areas as well. And you might have kind of other symptoms, but these are the two most common types of arthritis. So moving forward, talking about structural injuries. So I'm talking about like fracturing a bone, or, you know, you hear about in sports a lot, tearing those ligaments that we talked about, the ACL being a big one. So in sports, it can be a contact injury or a non-contact injury. So here we have a contact injury. So the terrible or unhappy triad is a term for a common combination of injuries, including the medial part of the meniscus, the MCL, so the ligament on the inside, and the ACL, that big important one in the middle. So that happens usually when the foot's fixed, and then you get a big rotation force and a big valgus force. So valgus is kind of going inward, right? So tipping the knee towards the inside. So all three of those going at once is known as this triad. But sometimes an ACL injury can happen just from a quick plant and turn pivot or a quick stop. Anything else where the tibia is forced quickly inward, forward, and rotated on the femur. So basically, there is a lot of talk about prevention in ACL injuries. Obviously, the trauma ones where a giant NFL player runs into you, you know, it's hard to prevent that. But a lot of them are non-contact. So without somebody here, you just plant quickly or stop quickly. And there's a lot of research on strengthening at the hips, strengthening hamstrings, preventing that kind of injury. So we'll get into that a little bit more, but car accidents obviously can cause bigger traumas than others. And then other causes for structural injuries are probably most commonly repetitive stresses. So maybe not a complete rupture of the ACL, but a partial tear of the ACL or a meniscus. You could be predisposed if you have excessive valgus or varus, excessive Q angle, hip weakness, too much mobility or too little mobility in your joints. Kind of just like any injury, you're predisposed with certain things. And it's also activity dependent. So if you're jumping all the time, volleyball player, something like that, you know, jumper's knee, they call the patella tendon, and then running, things like that. So repetitive stresses, kind of paired with what we talked about earlier, maybe biomechanically, everything's not fully aligned, but we'll talk about how to prevent that in a minute here. And then one more, I guess I should mention, is meniscus injuries. While I mentioned it here with the terrible triad, it's also very common with kind of just smaller things. So either repetitive stress or just kind of a sudden, like I moved funny. But the thing about meniscus injuries is that like asymptomatic people might have a small meniscus tear and it doesn't really affect them. So it's not an uncommon thing, but it can happen repetitively or traumatically. So there are a lot of different treatments that people do seek out for knee pain. Obviously, I will say that I think the best first-line treatment is physical therapy, because there you address not just the pain or the problem, but the root of the problem. Okay, so generally, my favorite type of treatment overall is prevention. So if I don't have to see anybody in here from knee pain, that's great because everybody's just preventing it. So a couple of factors to know about preventing knee pain. The hamstrings to quadriceps ratio. So most people have dominant quadriceps. They're typically stronger than the hamstrings. But if that ratio is too high and the hamstrings are like too much weaker than the quadriceps, which it's hard to test unless you have a very fancy, expensive machine. But we can kind of tell sometimes there are signs. And so basically making sure to strengthen your hamstrings and not neglect them and not just do exercises that are kind of quadriceps heavy. So the hamstrings, again, are the ones in the back of the leg. And then generally when strengthening things like that, knowing the difference between eccentric and concentric strengthening. So a hamstring curl would be concentric, you're kind of shortening the muscle. And then eccentric is lengthening. So like a good morning or deadlift, when you're lengthening down. And then we have kinetic chain considerations. So this is a huge factor. If you look at like sports teams that know they need to prevent knee injuries, like a lot of ACL, kind of ACL risk sports will do a lot of hip strengthening, core strengthening, things like that. So what we need to look at is ankle, hip, and spinal mobility, and then core and hip strength. So we're gonna do a little bit of this today. We're not gonna do every single thing, but. And then lastly, physical activity. Physical activity is your friend, whether you don't have knee pain and you wanna prevent it, or if you do have some knee pain. And that includes, like I mentioned, arthritis. So if you have arthritis in your knees, it's worse to kind of sit at home and say, you know, I have knee pain, I probably shouldn't go out. It's better to actually start walking more. Moving will help you. And then obviously being active, there are certain considerations. If you have pain, if it's just a nagging pain in your knee with certain activities or an ongoing thing, I would avoid a significantly aggravating motion. Like if a deep lunge hurts your knee really sharp every time, I would not do that. I would work on your weaknesses. So look at the rest of the kinetic chain, work on the hamstrings and quads separately, things like that, until you can do that without pain. And then if something is actually really painful and problematic, then get help. For other types of athletes, endurance athletes, it's always important to keep your training smart and make gradual training changes, because just like any other body part, the knee can have more accelerated injury if you're increasing your mileage too much, if you're running or biking or something like that. For contact sports, I've mentioned a couple times how important in prevention it is to strengthen your weaknesses. So if you have weakness in the hip or ankle, something like that, you got to spend time strengthening those. And that's why a lot of pro athletes, spend so much time off the field or off the track or whatever it may be, working on strengthening and other stuff too. So if you have questions, you can always email me here. It's jdiamond@beatreact.com. And then we do have both in-person or still telehealth appointments available. You can always sign up, call us and sign up for a free screen if you're wondering, is something going on that I need help with? nagging injury type of thing. And then there's our website as well. Okay, hopefully we're back here. Do we have a question here? Okay. I'm gonna get to that question later, if that's okay. So we're going to move on to demonstrate some exercises here. I'm just gonna angle over here. Hopefully everybody can still see me here. I'm gonna demonstrate a couple of muscle active releases with a foam roller first. So instead of just like applying pressure on the muscle, we're gonna apply pressure and then add a movement to it. So I'll show you two of those here to start. We're gonna be working in a line that's kind of not straight on the side and not straight in front, but at a little bit of a diagonal. So here we have the TFL muscle, which is that small muscle, that kind of hip flexor and rotator, kind of right in the bend of your hip. And to find that, I like to bring my leg up and then swing it a little bit out to the side. And if you're on the right spot, it kind of pops into your fingers here. So what I'm gonna do is lie on the floor and find that same muscle spot. And I'm gonna pop myself there, bend the leg that I'm working on, and swivel it side to side a little bit. So I'm activating that muscle. I'm feeling it contract and relax as I do this. And I'm having pressure through the foam roller. So after spending 30 seconds to a minute on that, we'll move down in the same line, kind of diagonally here, to the vastus lateralis, which is the outer part of the quad muscle. So I'm going to start towards my hip. For all of these, you never want to be on a bone, you want to be on the muscle. I'm going to have pressure here and then kick my knee. After a few kicks in one spot, we move down a couple inches. Usually these will be pretty tight and you'll know if you're in a good spot. And then one or two more spots kind of closer to the knee, but again, not on the joint or bone, just on the muscle. So that was TFL and VL releases. Next, we're gonna get into some strengthening exercises. So first one I'm gonna do is a lateral step down. So I'm standing at the edge of this step here, this stair. And what I'm gonna do is with one leg, it's a single leg exercise here, I'm gonna slowly lower myself and tap the opposite heel down. So when I'm doing this, I have to use my quads eccentrically because they're lowering me. But I also have to use my glute med muscle that we've talked about a couple times. It's so important because if I don't use it, you see this kind of knock knee that's happening here. So if I engage this muscle to keep my knee pointing straight, then I'm engaging that gluteus medius. So again, the gluteus medius is what kind of keeps our hips level and also keeps the femur from really jutting inward like that. So this is a good test too. So you can try to do this and watch yourself and see if you're even able to do it. It's more difficult than it looks. To make this exercise easier, you do a lower step. So often I'll start people on even just a 2-inch. This was a 6-inch here. So perform that on each leg. Another way to strengthen the glute med muscles without kind of without weight bearing, so kind of offloaded. We're gonna go on the floor on our side here. This is called 90-90. So I'm gonna take both of my hips to 90 degrees and my knees to 90 degrees, hence the name 90-90. Then I'm gonna straighten out my top leg and I'm just gonna lift it in the air. So it's kind of like a 90-90 setup, straight leg lift in the air, and I should feel it in this side glute muscle, side back glute muscle here. Just lifting straight up. And I don't want to let my hips tip backwards because then I'm just kind of swinging with my back. I want to keep my hips forward and only lift as high as I can. All right, the next couple exercises we're going to do is targeting the hamstrings a little bit. So obviously you can do hamstring curls, but you do need some equipment for that. And today I'm going to show you things that don't need really any equipment. So one we can do is a bridge. So it's going to get your glutes and hamstrings. And for a regular bridge, you're just going to go on your back, feet hip width apart, bridge your butt up and back down. To make it a little more difficult, you can do single leg. Press your leg over or float it. Just working out one leg at a time. Again, these are working both your glutes and your hamstrings. The next one we're going to do is good morning. So this is a good hamstring exercise. Gives you a little bit of a stretch too. So in a good morning, you're basically just folding with your hips back. Your knees are straight, but a little bit unlocked. You don't have to necessarily lock them out. But all your movement here is coming from the hips. So you're kind of folding there. You do want to make sure that you're not just bending from your back, but pushing your hips back and bending there. So if you need help with that part, I like to grab a broomstick or a PVC pipe and kind of stick it on your back so you can remind yourself, keep my back straight, use my hip hinge. All right, does anybody have questions so far there? Okay. Next, we're gonna do calf raises. So I'm gonna show them up against the wall here. You can see there. So I'm gonna stand up against the wall. For this one, we're gonna target all the different sides. Remember I said there were two sides of the calf muscle. So first we're gonna kind of leaning up against the wall. Knees are locked out for this one. Straight up, raise, slow on the way down. So that's a regular double leg calf raise. To target the inner part of the muscles, we're gonna kind of angle outward just a little bit. Same thing, up all the way, nice and slow down. And then for the last direction, we're gonna kind of pigeon toe a little bit. All the way up, slowly down. To make this one more difficult, you switch to just single leg. You'll really feel the burn more there. Once the first way gets easy, and you can still do the same little turns, just make sure your body's facing forward and just your leg is what's angling. So that was the calf raises. And that is, I believe, all the exercises I have for you guys today. Does anybody have specific questions? So all these exercises that we've done, you know, if you have a specific problem, your exercises would be more specific. But these are just some general good ones that most people can use. So if any of these hurt in some way, I feel like there are enough options that maybe you can try a different one. Good question. So somebody just asked, what's a good number of reps for these exercises? So again, really depends on the person. but say starting with 3 sets of 6 to 8, I would say. And then if that's really easy for you, then you can add more right away. So if you do them all, you don't really feel anything, it's really easy, you can add more than that. And then you can increase repetitions as you get stronger. After a couple times of doing them at 1 repetition, then you can increase your repetitions by like 2 on each set, I would say. So another question we have is sharing the recording. This recording will be emailed to all of you, so you can skip forward to this part, see the exercises, and kind of repeat them, because obviously I only did a few of each. So then you can kind of pause, do your set, and kind of go through it that way. Yeah, so somebody mentioned these moves look great for general kinetic support / strength, including, yeah. So that's the goal, is we want to be strengthening the whole kinetic chain because it's connected. You know, we're not just strengthening the quads and hamstrings, bending the knee back and forth, because again, there are so many other factors of forces on the knee. So good. All right, Mick, good question. General exercises for strengthening the knee patella area. So the step down exercise that we did over there is really good knee quad eccentric exercise. So the quads are the one that kind of encompasses the patella and then attaches below there. So any kind of eccentric quadriceps exercise like that, so lengthening the quads, so you're kind of like lowering yourself, is going to be good for patellar, the whole patellar complex kind of thing. And if that hurts, like some people have knee pain, especially front knee pain there by the patella, if they're going down the stairs or something like that, or downhill, then you start at a lower intensity, like a really small height. Another question, would squats be good as the hips bends? Squats are a little bit different. You know, the squat has adds a lot more knee flexion, and a squat is a great exercise too. Squat is a really good all-encompassing exercise. It gets glutes, hamstrings, quads. So it's a little bit different. It's a little bit less specifically like hamstring focused. And you do get more knee bend. So squats are great to do. Some people have knee pain doing squats, but hopefully that's something that can be fixed. Alrighty. Great questions, everyone. I hope this is helpful. Alrighty. Thanks everybody again for joining. I'm gonna hang out for a couple more minutes, so if you have questions, you can shoot them over. Thanks everyone. So I got a question here about running with arthritis in the knees. So that really depends if you're having pain, or if you just know you have arthritis in your knees. It could be a very different answer based on how you feel, how you're presenting. So I need a little more information. If you're having knee pain and you know you have some arthritis in your knees, I would say that would be a good time to see a physical therapist, and they can hopefully help you. Okay, so without pain, if it's, you know, you just happen to know that you have some arthritis, I would just say keep doing the other parts as well to keep your knees healthy, prevent future pains or issues, but running should be good to go then. Adding these extra strengthening exercises will help you though. All right, everybody. Thanks again. Have a good night.